Okay, so this is a 58-year-old male. He had a repair for a macular splitting RD 2 weeks prior with a pars plana vitrectomy, laser, and gas. Medical history is hypertension, herniorrhaphy. Systemic meds include micardis, hydrochlorothiazide, and vitamin D, fish oil supplements, and multivitamins. VA was 6/200 in the right eye and 20/16 in the left. IOP was 10 and 15. This is the first image.
I saw this guy yesterday. He's up to 20/30.
Oh, nice.
He's miserable for the distortion, but his vision's really good for macular detachment.
Wow. What is macula splitting?
Yeah, that's when the fluid goes right through the macula. Like
The edge stops.
the edge kind of hits the middle. And macula off, I don't know if you're gonna talk about this, but macula off RDs are, I think people still haven't agreed. Like, is it the fovea or the macula?
Yeah.
Right, and no one, and I've never seen, people are starting to maybe mention the literature some, because really, it's the macula doesn't matter, it's the fovea.
Yeah,
we care about, right?
Oh, yeah.
So typically, if it's like right up to the fovea, and that's when people often come in. So a lot of RDs fall into that macula off, macula on, fovea on thing. So typically, we mean the fovea, but
What's the definition of the macula?
anatomic,
What's the definition? Yeah, there's only one.
well,
I
yeah.
mean, it's like where there's two.
Two what?
layers
Two.
To what?
Or more.
Type cell, which cell is?
Yes, because
Which one?
Oh,
Anybody?
ganglion.
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 Good. Two or more.
So it's basically, yeah,
I never
K's.
forget.
It's two disc diameters out and a circle around.
And
So,
for patients, I've heard people
The
say
radius
it's the
is
size
two-
of a nickel,
yeah,
as long as nickels are still in circulation, I guess.
Honestly, for macula,
Yeah,
like
doesn't do
the
it
ones
right
that
away.
we see, it's by vision basically, because often the fluid, even if it's not like the full detachment, like the fluid getting there is enough to like separate. And so for us, it's just, do you have vision or not? And if you don't, like that
Smack
fluid
on,
must have
yeah,
extended.
the OCTs are great.
Yeah.
All right, go ahead, thank you.
Okay, this is a color finished photo of the right eye. I'm gonna assume this is the operative eye,
Yes,
but, so because the photo is blown up, maybe either the media is not totally clear, or maybe this is just, the resolution of the image.
Here's a better one.
Okay, cool. Well, it looks pretty clear then. It looks like the disc is really small now, but. But it looks sharp. It looks like there's a normal cup to disc ratio, normal color of the disc. The macula, there are these lightly colored striate lesions going through the middle of the macula. It seems there's no real edge to speak of, it's just an edge, but it's associated with 2 or 3 similar lesions in the macula. And
do you wanna go back one so we see the blown up? There you go.
at this point, it's hard to gauge the depth because we can't see it in association with any of the vessels. But I'm gonna say grossly, it doesn't appear to be elevated, although we don't have a stereoscopic image. The vessels, they look to be normal, and we just saw the periphery, which was also looks like there might be like a yellow creamy colored lesion superior.
yeah. You're doing a great job.
Yeah.
You're
very
doing a
nice.
great job. Good description. A good limitation of what you know about, you don't have stereo.
Right.
Well, that's important, because it's often when you guys discuss, you'll assume from monocular clues that you actually know what's going on, when you really don't.
That's what you said, Dr. Payton, last time I had a case. So
Pardon?
last time I had a case, I said something was elevated, and you said, well.
Oh, I nailed you on it?
That's how you learn, you gotta be stressed out, emotionally, has to be emotionally stressed out,
Yeah.
or you don't remember anything. All right, go
I think
ahead.
That's all I got on this one.
All right.
This looks like the IR, or yes, this is the right eye. And again, we are seeing this hyperreflective band-like
I'm an
lesion,
expert on this, I published in
which is central to the macula.
it. You should look me up.
Okay.
And otherwise,
Actually, this is not the guy I saw yesterday, I saw somebody similar to this. Okay.
okay. This is the OCT, this is a vertical slice of the right eye. We're seeing that there is a corrugated appearance of the nerve fiber layer in, I guess this is the inferior, the part to the right. Not really sure. if
It's
this is
probably
inferior.
superior. Yeah, you can look at the arrow. So if you want to, you see that in the left, I don't need to show these, but you see the arrow pointed on the top? On the left image is kind of super duper small. Yeah, the arrow is right here.
Oh, I.
Unless the line is brighter.
And then, and so that's the right,
Oh, that makes sense.
so, but I don't usually show those. I just, in this case, I did.
Is that generally standard, just superior on the right?
Yes, probably.
And here, this looks like a subretinal hyper-reflective solitary lesion associated with maybe a small amount of subretinal fluid and disruption of the ISO's junction.
Nice.
But otherwise, it seems to be like the architecture of the retina is otherwise seems to be unremarkable.
And it's right in the center of the fovea.
Huh.
It's just zoomed in of the same thing. I guess it's probably like the horizontal cut or something.
Of the right eye, that's right. We're just seeing more of this, or maybe there are two lesions. It looks like they may be one confluent lesion.
Well, this is a horizontal scan. If you go back to your color picture or your IR, maybe the IR is even better. So you see it looks like a snake, I guess, like a garden snake. Yeah, that thing going through the middle. So you're kind of slicing that two different ways. Like imagine a cucumber.
I see. Yes.
I'm eating a lot of cucumber lately.
Okay.
I like cucumber.
But it seems homogeneous with a sharp border and hyper-reflective. And again, I'm gonna say that's subretinal.
Yes.
Okay, yeah. And he had a vision of 2080 3 months later, and this is what it looked like.
Looks like the previously identified hyperreflective lesion is no longer present, and we're still seeing a little bit of a kind of a disrupted appearance of the ellipsoid zone.
And there was another one on the right previously, which is now gone.
Right.
There were two, I think, two lesions.
This is again the right eye again. Similarly, it looks like the lesion has since resolved.
Yeah.
Otherwise, it's normal steady.
Yeah, pretty much. And then history after that, he had a recurrent RD 3 months later, had surgery to correct that, then a macular hole, had surgery to repair that, and then chronic CME on Ozurdex every 4 months, and apparently recently 2030. So that's pretty good.
Wow.
Yeah.
Been through a lot. This is actually Beccaria did those surgeries. I saw the patient initially, then he ended up flipping to one of my partners, which happens. Yeah, so.
But in terms of the summary, 58-year-old male, status post-macular splitting RD repaired via pars plana vitrectomy, laser, and gas. Fundus initially showed horizontal linear white streaks in the macula. OCT showed hyperreflective subretinal undulations with disruption of the inner retina. What's your differential?
Okay, my differential, there's something called a retinal star fold that could be related. It's like post-operative RD complication or proliferative vitreoretinopathy, hypotony maculopathy,
Nice.
redetachment.
Yeah, yeah, Bill's pretty good, pretty good. I got some of those as well. But yeah, it's basically a macular fold, which I think is probably another name for the macular star fold that you were.
Oh, no, that's the star folds he's thinking is in PVR, you get a membrane on the retina,
okay.
it contracts and you get a star fold. So it was initially
Okay.
popped into your head because it is a fold, but that's different. It's totally
There's a lot of folds right now. I guess.
It's right. It's like a piece of paper, the retina, like a shirt. You can fold it.
Yeah. So yeah, this ended up being a macular fold. So it's an uncommon complication after retinal detachment surgery. It occurs in about 3% of rhegmatogenous retinal detachment cases, also known as a dry arcuate fold. There's a lot of risk factors for it: large and high riding scleral buckles, intraocular gas tamponade, especially with high volumes. And some reports also mention this with silicone oil. Superior bullous retinal detachment, especially one that is macular splitting, detachment involving the fovea, incomplete drainage of subretinal fluid, and also a head-up position. Pathophysiology wise, it's thought to be due to an incomplete removal of subretinal fluid. So when a gas tamponade is utilized, the residual subretinal fluid pools inferiorly and settles beneath the gas bubble, creating a retinal redundancy. After resorption of the subretinal fluid, the retina remains folded over itself, creating a retinal fold. Excessive retinal shortening due to a large scleral buckle can also create this retinal redundancy, and it can also be classified as partial or full thickness. In terms of signs and symptoms, start with the symptoms. Patient might notice some metamorphopsia, diplopia, visual field deficit, especially in the foveal involving folds. In a patient who has just peripheral retinal folds, they may be asymptomatic. There's 3 patterns that I found. It's not really reported too much. I guess someone had a case series and decided to give the patterns a name. So one of them is a ripple fold. And I'll show pictures of these, but it's a subtle undulation of the retina radially from the optic disc. The inner retina is gently undulated. The outer retina shows numerous distinct hyperreflective lesions. There's the taco fold, which is a single broad fold in the fovea showing large undulations of the inner retina with corresponding large outer retinal hyperreflective lesions. And this may later form an annular lesion once the fluid's resorbed in the outer retina called a photoreceptor rosette. And then finally, there's a displacement fold, which is a full displacement of the retina while maintaining otherwise normal appearance. And this has the worst prognosis with resulting residual symptoms. So here we have the ripple fold and then the taco fold. And then this is, I guess, what happens eventually. It forms this rosette, what they're calling a photoreceptor rosette after the taco fold goes away. And then there's the displacement fold where the retina is just displaced. Kind of reminded me of like a LASIK flap with the stria.
Doesn't work for me.
I'm one of the world's experts on this, and there was a review article I was asked to review because I published one of the first descriptions of this. It was one of my first cases at the VA here in Tampa. I put gas in an eye, I sat the patient up, and he got a horrendous fold. So what happens is the retina can stretch.
Yeah.
And it can actually stretch, so you get these redundancies. Fortunately, this fold was in the superior macula. And I figured out the way to avoid it is you always put the patient straight face down. You don't sit them up, they go face down.
For a while. Here, keep going.
And then what happens, I was stupid. I did learn from my own thing, and I caught some folds in the macula. I took a 20-30 eye and made it count fingers. And I couldn't unfold it.
Yes, I'm told.
I did not get sued over that, but
So funny.
I felt bad.
Yes. All right, go ahead. You're doing great, Kyle.
Yeah, and then finally it's just the treatment. So if it's a peripheral fold or partial thickness, spontaneous resolution is common, but surgical revision may be required, especially if it's persistent or anytime it involves symptoms for the patient. In terms of how the folds tend to resolve, the ripple folds may fully resolve without any residual anatomic change. Taco folds may leave the anatomic evidence of a fold, which is that photoreceptor rosette. And displacement folds usually leave an anatomic and functional evidence of a fold, so you probably want to treat those pretty aggressively. Surgical intervention, there's no consensus on the best intervention. I just found like a whole bunch of things people do for it. They usually have a combination of some of the following. So one of them is aspiration of any residual subretinal fluid if it hasn't fully resorbed. Subretinal injection of VSS to release any adhesions that may have formed, peeling the ERM or ILM to release superficial traction if present, surgical redetachment of the retina followed by tamponade with silicone oil or gauze, and again with the face down positioning, especially if it's in the macula, and perfluorocarbon liquid to dispel SRF, kind of like squeegeeing it out. And that's about it. I didn't find too many articles on this, to be honest. It wasn't really for DCSC either.
Yes, so some other things. So there's a bunch of stuff. So retinal folds, basically, like Reed said, basically you should, if you do things right, patients just don't get them. So in removing subretinal fluid, you had mentioned earlier about incomplete removal. What we know now with OCT scans is you never get complete removal of subretinal fluid. And actually you're best off, and there's recent studies on retinal displacement and pneumatic versus vitrectomy using the autofluorescence. Have you seen it? They're kind of cool. The autofluorescence images the vessels leave a footprint. So you can actually shoot an autofluorescent picture after retinal detachment surgery and see like where the vessel was and where it is which is really cool. And there's studies showing that with vitrectomy surgery to reattach the retina, you often do get some retinal displacement, whereas with pneumatic retinopexy, you almost never do. So basically, probably just gently put it, the fluid probably isn't the problem, it's more the positioning. So I have 3 positioning brochures I made from, I have my wife in all these different head positions. I'm trying to make this sound. We're putting her head different places and looking different places.
Did she do this to your wife and she had to?
Yeah, and I had to fuzz out the pictures a little bit, because I don't want a picture on there. And, for a brochure, so, because I think if you do it right, the people don't get folds. And the main thing, like Reed said, is face down. Face down, I had to face down, all my patients face down 2 hours after surgery, and then intermittently for the first 24 hours. Dr. Toth, who I super respect, who did the retinal translocations and has all of her patients' surgical side down. So if someone's half asleep on the waking up from a procedure, you can actually lay them on the surgical side for a while. And then the bubble kind of rolls them, then eventually you position face down. And then basically within a day or so, then they're in the regular position. But if you sit somebody up, you're gonna get a fold. The other thing I think is true is that I think the surgeons who get folds are probably the least able to treat them, because it's really hard to detach a retina. Like if you try, I remember in fellowship with one of the attendings who was not one of the super attendings. He was, I can't remember his name, but he was a Bascom Palmer guy, but he wasn't like a full-time Bascom. And he went in with somebody with a fold. And he's like, I'm just gonna redetach the retina, get rid of the fold. And it was unbelievable. You know, you can't just detach a retina. There's a lot of tricks to it. So it's basically.
It's one of those cannulas.
Yeah, because what you'd think is like, okay, I'm gonna attach the retina, I'll make a hole. I'll stick a silicone thing under it and I'll push fluid and the retina will detach. The fluid just comes right out the hole.
So that's
So
what
nothing happens. Like
you gotta have the 41 gauge.
Yeah.
Thing.
It's
The other
so
thing is,
small.
you got very limited time. This
Right.
is something you probably go at night or early the next morning. Cause if this sticks for 48 hours, it's not gonna work.
But a lot of them go away. A lot of the mild ones
Yeah,
get better.
well, the mild
It
ones
depends
go
on how
away.
bad they are.
And the only reason to attack them is if they're involving the macula. If
And
they're
they-
extra macula, forget it.
But I've never had one. I don't, and the other thing I hated about, I know this wasn't my case, is because if you look at the picture, oh, I can't scroll back. If you look at the color photo, can you go back to that? Where the drainage retinectomy is, I don't drain posteriorly anymore.
Yeah, but that
So-
was, that was.
This is the
a
way I
good
was
thing they did
taught.
it,
I was
because
taught to drain.
there was high indications to do that,
Right.
because they had a macula split. And they tried.
So
to
people,
minimize the
and it's
fold.
funny with this case, so people who drain posteriorly say, well, I drain posteriorly so I can get rid of all the fluid, so I don't get macular folds. So I think it's kind of
Yeah,
ironic
there was a
or
little
whatever,
fluid left, as
that
you
they
say.
even, there's always fluid left. So I always drain peripherally, because the reason not to drain there is if this person gets a recurrent, I guess they did get a recurrent detachment. I'll just see what the eye looks like now. I didn't do the recurrent surgery. This is gonna be a real bear to fix with a recurrent detachment, because you have to deal with that laser scar. So if you're doing retinectomies or you're doing whatever, all of a sudden you got this scar right next to the optic nerve. And it becomes almost impossible to reattach to that.
Well, the funny thing,
Because to reattach the retina, I always tell people, attaching a retina is kind of like fluffing your sheets when you're making your bed. So basically you want to have it free and then put it back. So anything that tethers it is just your enemy when you're reattaching a retina. So laser spots are just, basically, most of the time, if there's a laser spot somewhere, you have to make a retinectomy all the way back to that spot. So that means that this person, if this person got a bad detachment, they're gonna get a retinectomy right to the optic
Wow.
nerve to deal with that spot, or even posterior to it.
then the bleed and all
Yeah.
that. Yes.
Anyways,